Good afternoon, everyone. So after all these talks, we can understand that keratoconus is a dynamic disease. Even the risk factors, etiology, pathophysiology, treatment modality, diagnostic modality, everything is undergoing an evolution, and there is still scope of improvement in each and every area in this particular disease. So there is a rising trend in keratoconus that we can even see in our OPD. There is more of keratoconus patients, keratoconus suspects, pediatric keratoconus suspect, keratometry suspicion in pediatric patients. All this is going on a rise. And the highest incidence was noted from the year 2015 to 2019. And post 2020, there is a higher prevalence of keratoconus in the global population. So what we know about the pathophysiology, we know that the etiology is multifactorial. Both genetics and environmental factors play a role. Even family inheritance has a role. There is association with syndromes. Even the environmental factors like atopy, allergic conjunctivitis, eye rubbing. Now even the research is happening on whether rubbing with your knuckle, with your hand, even rubbing frequency or intensity, what is causing an increase in keratoconus, all these factors, even the risk factors are undergoing so many studies as to correctly define what is more risk to the cornea, whether it is eye rubbing as such, frequency, intensity, etc. And also allergy is on a rise. Consequently, in children also there is a rise in VKC, and keratometry values are also showing in the steeper side hence. There is biomechanical failure in the cornea which is happening. There is an increase in oxidative stress. The antioxidant levels are reduced. The corneal strength is broken because of the collagen matrix protein which is getting deranged due to eye rubbing or mechanical stress. And also adding on to it is the genetic predisposition factors. So still we have not understood the exact mechanism going on in a keratoconic cornea. So the research in that field is also going on. Basically, we need targets where we can have medical treatments to hold those pathophysiological changes. If there is a deficiency of antioxidant, can giving some antioxidant cause a progression reduction in keratoconic patients? The genetic studies are mainly being focusing on polygenic risk scores, and combining this polygenic risk score with a patient history or risk factors can assess. We can particularly tell that this patient may progress to keratoconus and this patient will not progress to keratoconus. So the near term goal will be to integrate these genetic scores with tomography biomechanics to stratify progression risk. There is a few of the studies have shown that acetylcysteine, which is an antioxidant, can be a potential treatment. That is also an area where the studies are going on. Various genes have been implicated, and further research, we need to know which all genes need to be included in a screening panel for keratoconus, which group of patients should we use this screening panel. So one of such screening panel is the AVAGEN, Avellino Lab, USA. Just a buccal swab is taken from a suspected patient. It is a panel of 75 genes, and in suspected patients or family history of keratoconus, but it is not available in India. So that is about the risk factors and genetic basis. Now coming on to the diagnosis, we have most modern imaging technologies, but what else do we need? Fourier domain OCTs, corneal biomechanics. It has been shown in studies that Corvis or ocular surface analyzers can show you changes in the biomechanical indices early on itself. So even before the topography detects a change in your cornea, if you analyze the biomechanics with Corvis, you might be able to detect at-risk corneas. We still doesn't have a criteria of progression, like this is progression in this patient. A universal protocol for definition of progression is not there. So each institute have their own way of detecting progression. Some people detect it at 3 months, 6 months, 1 diopter change in keratometry. So mainly we are looking for a change. So a universal criteria is still not, the heterogeneity of this progression definition itself is an area of research. So in the pipeline, we will have AI models on multimodal data. So AI models should come which will take into account all these data, topographic, tomography, biomechanical, also the demography of the patient, family history, if any. All these should be analyzed together to give us a risk score or something which will tell us that probability of this patient going on to keratoconus is high, low, or in what is the risk of that particular patient getting this disease. Then in vivo biomechanics, including brilliant microscopy and OCT elastography, is also a potential for treatment planning. We'll be able to analyze the cornea with motion, what is the changes happening in a cornea. Then what another research is happening is how we can monitor this eye rubbing or self-administered topographic techniques, how patient can from the home itself change or detect if any changes is happening in his corneal parameters. So these areas are also being explored. So this is motion tracking brilliant microscopy. So it can effectively characterize and tell you that focal areas wherever there is weakening. So that is a new research which is happening. The multimodal machine learning systems integrating parameters from Corvis, tomography and biomechanics. All these will help in early keratoconus detection. So now, rather than treating a patient with keratoconus, our full focus is on detecting patients early on, avoiding refractive surgeries or doing better refractive surgeries in those patients who are at risk for going on to a keratoconic cornea. This is Smart KC, which is a device to track eye rubbing in patients, which was also in a trial. Nothing has been come out to the market. Then there are biomarkers in tear fluid. So you can get tear fluid analysis done for interleukin 1 beta, galactin 1, galactin 3. All these can detect early keratoconus. So the values for these can be fed into a machine, and then by associated risk factors can be added. That also can give you data on early detection of keratoconus. So few concentrations of MMP9, interleukin 6, receptor for advanced glycation end products. All these in tear fluids the studies have shown that all this will give you an idea if the patient is at risk for keratoconus, or if already values are very high, chances of keratoconus is high. In therapeutics wise, the gold standard for preventing progression still remains the epithelium off, but epithelium off technique has its disadvantages, infectious keratitis being the most dreaded one. So we have to find solutions to overcome this. So epi-on techniques are being investigated. And in other than that, vision, how can we improve? Contact lenses, advanced contact lenses are coming. Then we are combining CXL with vision correcting procedures like PRK, intracorneal ring segments. For advanced diseases, still our resort is DALK or PK. Recently we have additive procedures like KSOS and intralenticular implantation of stromal lenticule or smile lenticule. Delaying graft. We want our young patients to not go into a keratoplasty kind of situation. That has become the major objective. CXL innovations, we brought about the accelerated protocols, but we still don't know if they are equally efficient, because many studies show equal efficiency, but there are few studies which also show that the standard protocol is still the best. Transepithelial CXL with enhancers, there are many newer ones coming up. Pediatric AC, that is an area where we still need to progress in research. We don't faster progression even with CXL, that is not halting. Pediatric specific protocols need to come so that we can halt progression in pediatric patients. In treatment, there are drug-based therapy. There is one drug which is under FDA phase 3 trials, that is IVMed 80. It is a copper sulfate drops that is under study. So basically this lysyl oxidase enzyme activity is found to be low in keratoconus patients. So copper acts as a catalyst for that particular reaction. So naturally improving cross-linking in the cornea is what we are aiming at. Then to enhance the CXL with epi-on procedure, there is epi-smart, in which sodium iodide is added with the riboflavin solution, so that that penetration less is due to the epithelium. Sodium iodide acts as an enhancer and better penetration happens. So this is also under FDA phase 3 trials. Epioxa is also a modified riboflavin, but this has been approved by FDA now in October. So this is a modified riboflavin with epi-on. If we put this riboflavin, it will have better penetration, and this kind of epithelium on CXL is getting FDA approval, and we might be age above 13 years is eligible. So this might be coming into the market soon. There are CXL contact lens also. All these are in trial only. Rose Bengal assisted CXL, that is also cross-linked stroma, anterior 100 to 120 microns of the cornea without any toxicity. We are able to, that is also under study. We have to further study and find if oxygen plus Rose Bengal can be an effective alternative to riboflavin. Then there is CXL innovations like customized CXL, where we have to customize and give UVA to particular areas in different energies. CXL with photorefractive, intrastromal, all these are under study. Surgical frontiers, we have Bowman layer inlay or onlay transplantation, intracorneal ring segment with CXL, then regenerative approaches wherein stromal tissue engineered. Stem cells are being injected into the stroma so that we want more stromal cells to come and increase the stromal thickness. Artificial cornea is being made, which can be an alternative to the global shortage of cornea tissue for transplantation. The minimally invasive keratoplasty techniques like Bowman layer transplantation, femtosecond laser assisted intrastromal implantation. The Bowman layer transplantation as well as both these techniques have been found to be an option to treat advanced cases. So they will stabilize the ectasia is what studies have been found to have. Additive keratoplasty procedures like KSOS, corneal allogenic intrastromal ring segments, are being implanted into the cornea so that the astigmatism and stabilization of corneal tissue happens, is another area where research is happening. So in customized KSOS, it has been found that there has been significant flattening, changes in K1, K2 and Kmax with the procedure. Also improvement in visual acuity and reduction of higher order aberrations have been noted in studies. In lenticule assisted implantation of lenticule also there is found that the visual acuity improves, cornea stabilizes is what studies have found. What are the key gaps? We need a standard protocol for progression assessment. We need RCTs where we will find out where accelerated is transepithelial versus standard, which is the best protocol. What can we do for as medical treatment to modulate matrix remodeling, which is the underlying pathology. Stromal regeneration strategies, rigorous evaluation is needed on that side also. Our take home message is that detect earlier, personalize the treatment, multimodal AI plus biomechanics to identify fast progressors, early detection. CXL remains the cornerstone for now. Which all patients need to be selected for accelerated epi-on customized protocols, that we will find out eventually with the research. So the future is always going to be biomechanically guided reinforcement and stromal regeneration, or whatever treatment which can help us delay or avoid transplantation in these patients. Thank you.